Welcome to talk 3 of our series, Carrying Code Correctly the First Time. We're going to talk about the alignment of quality, risk adjustment, and prior authorization with a slightly different perspective where it's embedded directly in care delivery. I am Dr. Matthew Burton. I am Principal Physician Informatician with the SMILE Clinical Intelligence Group. All right, so sort of setting the stage for the problem. So right now, there are really 3 different silos or programs, quality, and in particular quality measurement, but you can think of that as including population health, risk adjustment, and accurate coding to accurately reflect the risk of individual members, and prior authorization, so coverage determination, particularly for more constrained resources, whether they be interventions, diagnostics, or services. However, even though those are currently in different silos, managed by different teams and tools, often even different information, it's really the same patient, the same data, the same conditions, and the same drivers that underline all of those, and the same best practices. So this siloing historically actually has been a mistake. So they all are really expressions of precision best practice, just looking at different dimensions or perspectives on best practice. Right. So first, if we look at quality and quality measurement, look at the economics. So obviously payers don't just care about their HEDIS or STARS ratings. They're trying to identify and mitigate risk, both clinically and financially. And so compliance with best practice, though, is measured in broad strokes. This often misses opportunities for high quality or high value care, particularly for higher risk patients. These public measures, such as HEDIS or even the CMS ECQMs, though, are used to measure and incentivize performance. So looking at trying to measure with these broad strokes, and then even measure and manage to these measures that take broad strokes. So the gap really is that these public measures and then associated risk mitigation don't fully align. The public measures don't address patient-specific issues or risks and the opportunities to mitigate them, and particularly for those that are most financially at risk. So the payer, provider, and ultimately patients benefit from better alignment or compliance with true best practice, right? And it's shared upside across all 3. So how can we start to address that particular issue, but not in its own silo? So let's look at risk adjustment. And so risk adjustment, so the problem is there are very sick patients that tend to break actuarial models, particularly if there's not sufficient information, particularly in claims or administrative data. And without incentives, payers may avoid taking on, and even providers may avoid taking on these higher risk patients. So CMS, through their Medicare Advantage plan, have introduced a risk adjustment model. So as long as that risk is properly documented and then coded and submitted. But the gap really is where payers and their provider partners lose revenue when that documentation and or coding doesn't occur. And so there's a lot of rework that can occur trying to close that gap in documentation or gaps in coding. The opportunity here really is both on the payer and provider side, where they benefit from more accurate and complete documentation and coding, and be able to share on the upside. And then third, we have prior authorization, right? And so payers need to ensure that interventions are medically necessary, that they're safe and cost effective. So really, truly best practice, right? So the problem really is, regardless of structure, right, financially responsible parties or plans do not have unlimited resources for providing care. So they look at prior authorization, CMS, and health plans, look at prior authorization as a means in order to determine whether they can reimburse particularly high cost interventions and services that may or may not be appropriate for or most cost effective in particular situations. So the gap here is that current prior authorization processes and rules introduce a lot of non-value added work, both on the payer side and the provider side, arguably even on the patient side. If they have to return to their provider and ask for a different medication or a different kind of test. And these rules are often applied in broad strokes that in many cases may run very much counter to mitigating clinical and financial risks for certain patients. So both payer and patients benefit from clinically appropriate and cost-effective interventions. So how do we actually align these three perspectives on best practice and quality or value, high value? So let's look at some of the unifying insights, since we have the same patient, the same data, the same inferences, and the same best practices that are really underlying all three, right? For quality measurement, prior authorization, and risk adjustment. Right? And so we talk about these case features, and these case features are clinical insights that provide high resolution, precision clinical information based on both deep phenotyping and precision applied best practices. And these are the things that we discussed in Talk 1 that often were not addressed in creating the kind of content, this kind of content historically, because the knowledge engineering effort that it takes in order to develop that content. So let's walk through an example. Okay. And so here I'll just give you a little bit of orientation, right? So I'm a nurse care manager in this particular, I'm a provider in this particular situation. I have this patient, they're on Medicare Advantage. They have diabetes. They looks like they may or may not have chronic kidney disease and a few other complications, as well as some additional risks. I can see that across the top. Right. And so just orienting you here, I've got along the left-hand side, I've got these case features, and these are information about the patient. Some are with respect to diabetes, some are with respect to chronic kidney disease. Those are the two conditions of focus. I can see to the left of the line, I get to see sort of the historical timeline view or trends. I can see there's some documentation of the diagnoses. I can see what medications they've been on. I can see how things like their glycemic index or A1C has been progressing over time. For chronic kidney disease, I can see that I've been monitoring their kidney function or kidney status with EGFR and UACR. I want to call out a couple of things here. So on the right-hand side, I can see, so I've got these sort of indicators that I need to take an action. On the right-hand side, I can see that there's some time that I need to take these actions in. So it looks like there's some action I need to take on their medication or may need to consider on their medication, and then follow up on their glycemic status, see if it was impacted by whatever change or alteration I'm looking at in their medications. I can also see that some additional test for kidney function may also be indicated. And so this gives me sort of that situational awareness for where the patient's been, how they're progressing, what are the things that are currently going on and may or may not need to be done. I'll call out a few other things on the screen as we progress, but we're going to just stay in for now this quality or quality improvement perspective. So I'm going to try to address their A1C that appears to be outside their goal range. And I get a set of recommendations. And so for this particular patient, in part because it appears that they have some decreased kidney function and or kidney disease, that they may be indicated for a SGLT2I. and that's been recommended. I see a few other alternatives that may come into play that I can consider. I also see that this particular patient needs a follow-up hemoglobin A1C within 90 days to see if they're responding to that medication, right? As well as follow-up EGFR and UACR. In part, it was, it appears that they missed their last screening. And I also want to see if there's been any impact on their kidney function with my medication change. So that's purely in that quality perspective. But what if instead of just looking at the quality and alignment to HEDIS and or ADA guideline recommendations for how to manage this patient, what if I actually have a little additional information or application of the same content? Again, as the provider, first time going through taking care of this patient in a single encounter, right? I can actually see those recommended medications that require prior authorization. I can also see information over here to the left-hand side for the documentation requirements for that prior authorization rule. So some of the questions that are being asked, and then information that's being pulled from the data. So you've seen in prior demos how our prior authorization application works and is able to do both dynamic and adaptive questionnaires. But in this case, it's actually pulled directly into that recommendation process, right? And so I have all the supporting information here along the side. I can see that this particular medication appears to maybe meet the prior authorization requirements. I haven't submitted it yet. It hasn't gone through adjudication. But I can actually see that, it appears that both the guideline recommendation and prior authorization rules together have been met when I'm ordering this medication. So now you can see how we pulled prior authorization into directing quality and quality improvement and selecting not only a clinically effective drug, but a cost-effective drug as well. Now, I want to step back to the screen before, a couple of things that I skipped over. So along that top row, right, under diabetes, I can see that I had diabetes without complications. Then I had diabetes with stage 2 chronic kidney disease, and that's in the prior year. But in this year, I have now not documented that this is diabetes with stage 2 or higher chronic kidney disease. In fact, it may be higher at this point. If I go under chronic kidney disease, I can even see the staging. I can see that last year they had stage G2A1, but no staging was documented this year, and that might play into why that more accurate and specific diabetes code was not documented, or diagnosis was not documented. And so you can see, in addition to the clinical activities that I need to take, I have some documentation recommendations that I need to consider. Okay. And so based on this recommendation, again, if I look at what I need to document in this particular case, first, we're looking at, just to orient you to the screen, we're using the MEET criteria, or monitor, evaluate, assess, and treatment criteria for this particular patient. It shows me things that I might consider adding to my documentation, right, as far as discrete data, but as well as things like smart phrases that I might want to include in my narrative, right? And so I can see some things here that are being recommended that I might want to state, and how I might want to state them in order to support a particular level of diagnosis that the data appears to support, as well as how I'm assessing, evaluating, and thinking through my medical decision-making process for how to treat those patients. Right? And so I get those recommendations for my documentation. Right, so I can support then the appropriate diagnosis. And so for that diagnosis, you can see based on both data and on documentation, right, that a few diagnoses may be supported here. Right, in this case, I'll focus on this one where not only we missed that the patient previously had chronic stage 2 chronic kidney disease, but based on their current or most recent EGFR and UACR, they actually have stage 3 or greater chronic kidney disease. And these are things that I also want to add onto my problem list and will end up in the encounter documentation. And so you can see how in this particular case for this patient, right, there's, if we look at current state, we don't have the provider seeing the patient, missing care gaps, having to go through a process where a nurse care manager at the payer picks up on the potential for a care gap based on claims data or other data that they have, right? Has to circle back around to the nurse care manager or nurse quality director at the provider organization, who has to circle back around to the provider, possibly get another encounter or visit with the patient, and address those care gaps, right? So there's rework that's involved there. And again, I don't similarly have a separate group who's looking at things like, that medication that you want to use to address the care gap, needing prior authorization. Again, a nurse quality director at the provider organization reaching out, faxing in information on filling out a form, providing information on prior authorization, waiting for a prior authorization before the provider can actually submit the prescription, in this case, to a pharmacy for the patient to go and pick up. Right. And I also don't have all of the chart chase that occurs and review by certified or qualified billers and coders that go back and have to do a review process, review the documentation, review the coding, provide feedback to the provider organizations to go back and correct their coding and or documentation. Right. Instead, what we have is first-time quality. So care and code correctly the first time. The provider sees the patient, they deliver best practice care, they document that care, they add the appropriate codes, the orders that they go to place, they fill out the documentation requirements for prior authorization, and may get prior auth adjudication in near real time. Then document any risk or the clinical rationale that needs to be documented to support certain diagnoses that are coded correctly. And in this case, there's no rework back and forth between provider and payer organization, which is using really high value resources to do a lot of that rework. And in this case, what we've done, the same capabilities that we've shown you in other presentations and demos, right, on sort of for addressing current state needs, right, actually similarly enable future state. And that future state can actually move a lot of this work completely out of the system entirely and where appropriate into the provider's workflow in directly in direct patient care. So how is this happening? Well, a couple of deployment options and implementation patterns. As I mentioned before, the capabilities that we've shown you here are the very same capabilities in Intelligence Hub currently, and they just can be implemented with different provider partners in a couple of different patterns. And we've got 3 general patterns here that we'll show you. So one is in a payer-hosted shared instance. So this would be where the payer funds and operates this instance, and providers have access via the existing payer portal. For instance, it does not require direct EHR integration and data such as what's retrieved for prior authorization documentation requirements don't get persisted on the payer side. In the middle, for larger provider organizations, we can look at a provider-specific instance where the payer may subsidize this instance as part of their value-based care contract or shared risk contract. Provider integrates the capability into their EHR via Smart on Fire. And then this does provide a little richer experience on the provider side with higher data resolution and reducing some of the administrative, additional reduction in administrative burden on both payer and provider side. And then the third tier, which is really for your more technically capable provider partners, there's a means of just interacting through data or insights, right? Where structured fire output through the reasoning capability is delivered back to the provider's EHR. There's not necessarily any specific user UI needed, user interface needed. The data flows directly into the provider's EHR. And so this allows maximum flexibility for those fire-capable organizations or organizations that have fire-capable EHRs and the resources to implement them. So anyhow, that is an overview of 3 general patterns. Obviously, you can talk to us about very specifics of the kind of deployment options. Any given payer organization likely will have a mix of these types of provider partners. And so the same capabilities, the same information, the same data, and the same content are still driving all 3 different deployment options and implementation patterns. So that concludes our discussion on care and code correctly the first time or first time quality. If you'd like to discuss your modernization journey with us, we have talked to you previously about OmniVera, which is our trusted data foundation, OmniQ, which is our quality measurement and clinical intelligence solution, OmniComply, which is our regulatory compliance solution, and OmniConcierge, which is our trusted partnership providing services for things like those implementation patterns that we discuss. And that's all we have for today. Thank you for your time.